All right, so let's talk a little bit about the secondary lymphoid organs. So the first one we'll talk about here is the spleen. When I think about the spleen, I like to organize it into two categories. I think about the white pulp and I think about the red pulp. Now what I want you to do is just to think about how you would get into the spleen, right? If you were a cell or an antigen potentially, you'd come in through an artery here, okay? And you'd eventually kind of go off into one of the arterioles. And eventually, as you come out of this arteriole, the first thing you're gonna hit here is gonna be this white pulp. Okay, so you can see this white pulp is surrounding the arteriole. Okay, so that's the important thing. Now, what is in the white pulp? So there's two kind of major things. We got B cells and we have T cells. We have them both. The B cells are going to be in follicles. When you hear follicles in the lymphoid system, right, you're going to think about lymph nodes, you're going to think about the spleen. In both cases, follicles represent B cells. Okay, so that's going to be pretty consistent throughout. So remember that. Periarteriolar lymphatic sheaths, if I took a cross section here, let's just say that I, blow this image up, right? I blow this image up and I have, I'm going to do this in kind of 3 dimensions. Here's my arteriole coming in. And then, maybe around this arteriole, I might have a bunch of T cells. Okay, let's just put a bunch of T's here. So here's a bunch of T cells. They're all kind of surrounding this vessel as it comes in. And remember, this whole thing around this arteriole is going to be surrounded in white pulp. Okay, so this is all going to be white pulp. So this whole area here, it's all going to be surrounded in white pulp. And that area around the arteriole, remember it says right, around arteriolar lymphatic sheaths. It's almost like a sheath of T cells surrounding that arteriole. The whole purpose of that is if I have antigens coming in, right, those antigens can be recognized by the T cells. Okay, so that's the point. That's why they're there. So it's a dense lymphoid tissue surrounding the arterioles as you come in. Again, all in the white pulp. And like I said, we also have follicles there. Those follicles are going to have B cells. What are the B cells going to do? These B cells essentially will be producing antibodies. Okay, and so when we talk about things like, IgM, right? This is an immunoglobulin M. It's a type of immunoglobulin. IgG, right? IgE, all of these things, right? B cells are going to be producing those, right? These are going to be antibodies. We're going to draw them like that most of the time. But some of these, like IgM, they're going to have really, big structures, okay, potentially. They're all shaped a little differently. We'll talk about that. But the point here is that the B cells will be making antibodies. The T cells here are going to be recognizing some of these antigens coming in, and we'll talk about all the details of what they're going to do. Okay, but for the purposes of this video, white pulp, follicles, B cells, periarteriolar lymphatic sheaths, T cells. Now, what happens when you go from the white pulp to the marginal zone? Okay, so the marginal zone, first of all, what is the marginal zone? Marginal zone is the area between the white pulp and the red pulp. So it's kind of like this really smaller zone here. I'm just going to put marginal zone here. And, if we were to kind of put a line out here to represent it, you can see here's all white, here's all red. And so it's this area kind of right between the two. Okay, so that would be your marginal zone. Okay, and this is a gross oversimplification, but it's really all you have to know in terms of this. Now, the marginal zone, you just have to remember there's a lot of phagocytic cells there, right? The antigen presentation from things that are coming from the blood can happen here. You can have macrophages or antigen presenting cells that can digest bacteria, foreign substances, present these to nearby lymphocytes. That's really the extent of it that you'd have to know here. Now, what about the red pulp? Okay, so you can see the red pulp is all this area around the white pulp, again, separated by the marginal zone. Now, red pulp is kind of easy to intuitively make sense of. So the red pulp is going to manage a lot of the red blood cells. Okay, so the arterioles are going to come in and they're going to go into these sinusoids. Okay, so let me kind of draw this out for you a little bit. So I'm going to use this pink color here. So let's just say this is my red pulp back here. Okay, again, the marginal zone is going to separate the white pulp and the red pulp. Red pulp is going to be back here, but think of your red pulp as having, maybe like more of a web-like characteristic shape. At least that's kind of how I think about it. Now, the reason I think about it like that is because the red blood cells that come out through here, right? The red blood cells that come out through here, they're going to have to traverse that red pulp and the sinusoids that go along with it. And they're going to have to come out of the other side. So take a look at this, right? So if you were just coming in here, right? If you were a red blood cell and you came in through this arteriole, you're going to have to traverse the white pulp, traverse the marginal zone, and get into this red pulp. And from this red pulp, you would eventually get to a venule and you'd find your way out and eventually get into the portal circulation, right? Through the splenic vein, etc. The point is, though, is that you're coming into this arteriole, you got to traverse this red pulp. Okay, so if you're a red blood cell, you got to get through the red pulp. And the red pulp is going to have a lot of these kind of sinusoids that are made essentially to try to trap the old red blood cells. Okay, because initially, right, you have a red blood cell that has a characteristic shape. But over time, that red blood cell is going to get very rigid and it's going to lose its flexibility, okay, and lose its shape. And so it's going to be unable to traverse through these sinusoids eventually. What happens is, if that's the case, these macrophages, right, they're going to come up and eat up that red blood cell. The concept, though, is, let's just say you had an infection here of this red blood cell. Okay, so you had some infection in that red blood cell. Well, if we had the ability to eventually destroy these red blood cells, because maybe the infection destroyed the structural integrity of the red blood cell, right? So the sinusoids would pick up on that, macrophages would digest this red blood cell and destroy this red blood cell and potentially the infection along with it. But if you had a patient that did not have a spleen, you wouldn't be able to digest these red blood cells, number one. And so you're going to get very characteristic red blood cell shapes, which we'll talk about in the hemonc section. I don't want to get too off track here. The other thing, though, not only will you get very characteristic red blood cell shapes, but you'll also have difficulties, if you don't have a spleen, in clearing infections that attack red blood cells, like malaria. If we're talking about a patient that's from a more underdeveloped country where malaria is endemic, that's usually how they'll tee up the question initially, right? That's going to be very classic. If they have their spleen removed, that's going to be a problem in a lot of these patients. What about in the US, northeastern US? What are you thinking about, right? Of infections of red blood cells, you might be thinking about babesia. Things to keep in mind. If you have a splenectomy, my point is, don't just go to encapsulated bacteria. That's the classic kind of old school way that's presented, but also remember malaria and babesia exposure as well. Now, let's just take a step back here. I explained this part, but why, if you had your spleen removed, would you be at risk of these encapsulated bacteria? Okay, so let's clean this up for a second here. Okay, let's just imagine here I have some bacteria. Okay, so here's my bacteria, and normally I have some antigen presenting cells here in my body, and these antigen presenting cells, when they see this bacteria, they come in and they try to eat up this bacteria. Okay, so that's essentially what they would do. They undergo phagocytosis, present the antigens, right? And we'll go into all the details on that in a perfect world. However, there are things that bacteria can do to prevent that from happening. One of those things that's very classically asked about are going to be these capsules. Okay, so bacteria can have a capsule. Now, the three classic ones to know of that do this, the biggest one, number one, strep pneumo, by far. That's the important one to know. If you can only know one. Haemophilus influenza type B, Neisseria meningitis, those are also important. So they have a capsule. What this capsule does is it can prevent this antigen presenting cell from being able to digest it because it has this rigid capsule on it now. Okay, so the antigen presenting cell needs a way, essentially, to try to digest this bacteria now, right? It can't do it through just phagocytosis alone. So what can happen is, right, we have antibodies, right, in our blood, right? Let's just say we have some IgM antibody here floating around, and maybe this IgM antibody binds to the surface of this bacteria, okay? And in doing that, now this bacteria is essentially tagged for destruction. So now certain antigen presenting cells can bind to the other portion of this IgM. They can bind to this, and that will give them the signal to say, hey, you can digest this bacteria. Okay, and now the antigen presenting cell can engulf our bacteria again. Okay, so let's say this is my antigen presenting cell. Now the antigen presenting cell can engulf the bacteria because there was the IgM, there was the antibody on the surface. The other thing is, when you start tagging these bacteria, you open the door for complement. Okay, so you can have some complement floating around in the blood, particularly C3b, right? That will bind here and it would help destroy this bacteria eventually, right? So that's the concept. The concept is, if you have antibodies like IgM, they can bind to the surface of bacteria, target it for destruction. If you don't have a spleen, that's a problem because the spleen is very important in antibody production. In fact, nearly half of the body's total immunoglobulins come from the spleen. So if you don't have a spleen and you have encapsulated bacterial infections, right, that's a big problem because you can't tag that bacteria for destruction. And so again, if you don't have a spleen, you want to be very cautious with strep pneumo, Hib, Neisseria, so you vaccinate these patients because we have a vaccine for each of these, right? All three of these we have a vaccine for. The point is that you can vaccinate these patients because they're at increased risk of infection with encapsulated bacteria. Now, in what situations would a patient not have a spleen to begin with? Well, trauma is a big one. Particularly, think about patients that have mononucleosis, EBV infection, younger kids, usually adolescents, 16, 17 years old, right? If they have mononucleosis, that spleen's at risk for rupture with trauma, right? So remember, left upper quadrant between the 9th and 11th ribs usually is the area we're talking about. Now, hereditary spherocytosis, we'll talk about this on HEMONC. What's the treatment for it? Definitive treatment, splenectomy, right? You take the spleen out, but then these patients are at risk, right? You got to make sure they're vaccinated. Sometimes this vaccination schedule is actually even more aggressive than a patient that didn't have a splenectomy. And the same is true for sickle cell disease. In sickle cell disease, these patients can have a spleen physically, right, in their body, but it doesn't mean that it's working correctly. Sometimes all of these sickle cells can cause there to be decreased filtration, decreased perfusion to the spleen so that it eventually just doesn't work. It can atrophy. Okay, so that's something to keep in mind. Also keep in mind that a lot of the platelets are stored in the spleen and can also be filtered in the spleen.